Hello, everyone. I'm Dr. David Pedler, Scientific Director of the Canadian Institute for Military and Veteran Health Research. Thank you all for taking the time out of your busy schedules to join us for day 2 of CIMVHR Virtual Forum oral presentations on the veteran population. We have a fantastic lineup for today's sessions. Before we begin, let's acknowledge the Indigenous peoples of all the lands that we are on today. While we're meeting virtually, I would like to take a moment to acknowledge the importance of the land which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. Before I introduce our next speaker, I will invite Dr. Cécile Mélavier-Jagreau to say a few words.
Merci David. C'est un grand plaisir de présenter en tant que vice-rectrice à la recherche le Collège militaire royal du Canada, qui est l'une des institutions fondatrices de l'Institut canadien de recherche sur la santé des militaires et des vétérans. Nous connaissons les particularités liées à l'expérience militaire, autant pour les membres en service, les vétérans, ainsi que pour les proches. Nous explorons aussi les besoins spécifiques des professionnels similaires, tels que les premiers répondants et bien d'autres. Les présentations de haut calibre qui vont vous être présentées montreront à quel point la recherche émergente prend en compte les besoins différents des femmes et des hommes, et comment la recherche détermine souvent les politiques. Ces avenues et bien d'autres vous seront présentées ici au forum au cours du prochain mois. Nous vous y attendons en grand nombre. Bon forum!
It is now my pleasure to introduce a longtime colleague and friend, Dr. Alexandra Eber. Dr. Eber plays many roles in advancing health research for Canada's military personnel, veterans, public safety personnel, and their families. She is the Chief of Psychiatry at Veterans Affairs Canada, the Chair of the COVID-19 Readiness Resource Project, and the Co-Chair of the Canadian Military Sexual Trauma Community of Practice. Alex, thank you for being here.
Thank you, David. In Canada, over the past 9 months, the curtain has been drawn open on the reality of military sexual trauma, and we have all become aware of the devastating effects of MST because of the courageous actions of many of our still serving members and veterans who have come forward to name it and to tell us of their experiences. Because of this, I am very pleased and proud to introduce this year's Veterans Affairs Canada keynote speaker, Dr. Amy Street. Dr. Street is the Deputy Director of the Women's Health Sciences Division of the National Center for PTSD within the U.S. Department of Veterans Affairs, which focuses on the special issues of women and PTSD. She's an Associate Professor in the Department of Psychiatry at Boston University School of Medicine. Dr. Street received her PhD in clinical psychology from the University of Georgia. Dr. Street researches sexual harassment and sexual assault in veteran and civilian populations. Her research also examines gender differences in traumatic stress with a focus on military deployment. She has received funding from the Department of Veterans Affairs and the National Institutes of Health and has been published in many peer-reviewed journals. She is also actively involved in the treatment of veterans and serves as the co-director of WOVEN, the Women Veterans Network, a national peer support program designed to improve social support and quality of life by fostering connections among women veterans. Please note, because of the content being discussed, some of the material in Dr. Street's presentation may be disturbing to some people. If you find you're becoming upset, please pause to take care of yourself. And now it's my great pleasure to welcome Dr. Street to talk to us today on providing care for survivors of military sexual trauma. Dr. Street.
Hello, everyone. I am Dr. Amy Street, and I'm very excited to be here talking with you all about what I think is an incredibly important issue for all of us, and that's the issue of how to care for survivors of military sexual trauma. I have received funding for this research and related research, but have no conflicts of interest to disclose. I should say, as an employee of the United States Department of Veterans Affairs, that I am not speaking on behalf of the department today. The views presented are my own. I want to start our conversation today by setting a little bit of a framework of the extent to which this issue has received very extensive attention over the past probably 20 years, with increasing attention over the last 5 or so, both here within the United States and certainly within Canada as well. In both countries, I think a lot of the media coverage has focused on specific high-profile incidents of sexual misconduct among military forces, but also focused on the breadth of the issue in terms of the number of people who are impacted, and our governments and military systems working to find better and more effective solutions to these critically important issues. Understanding that kind of framework, I want to dive into just understanding the terminology that I'll be using today to make sure we're all on the same page. I'll be using the term sexual assault pretty frequently, and sexual assault refers to physical sexual contact that occurs without the victim's explicit consent. So 2 factors. One is sexual assault involves some sort of physical contact, and that there is a lack of consent, whether that happens because the victim was overpowered or physically forced or coerced with threats of harm or abuse of authority, or because the victim was unable to consent, either because they were intoxicated or asleep or cognitively impaired in some other way. Now, rape is a very specific, severe form of sexual assault that involves sexual penetration explicitly, but also occurs without the victim's consent. I'll also be talking a lot about sexual harassment today. And I think we can think of sexual harassment as involving 2 types of behaviors. The first is hostile workplace harassment. And those are unwanted sexual experiences that occur in the workplace and create an intimidating, hostile, or offensive working environment. So these are things that we would see like frequent sexual jokes or sexual propositioning or commenting in a sexual way on someone's body. That's hostile workplace harassment. Whereas quid pro quo harassment is a type of sexual harassment in which participation in or tolerance for unwanted sexual experiences is required as a condition of employment, or is used as the basis for employment decisions. So within a military setting, we would often encounter experiences like, I can give you a better duty assignment if you go along with what I'm asking you to do, or I'm going to give you a negative performance review unless you participate in the sexual behavior with me. So it consists of a broad range of different types of experiences, but all of which share the idea of unwanted sexual experiences happening within the workplace. I'll also be talking a lot about military sexual trauma, or often abbreviated MST. This is a term that's used in the United States Department of Veterans Affairs, but also much more broadly by others in the scientific and advocacy communities. And it refers to experiences of sexual assault or sexual harassment that occur during military service. So essentially all of the types of behaviors that I just described on the last few slides. And I understand from my Canadian colleagues that there's actually work ongoing now to identify an official Government of Canada definition of military sexual trauma. I wanted to show this slide about a continuum of harm because it highlights one of the things that I actually like about the definition of military sexual trauma. And that is the fact that it is such a broad term that includes so many possible types of behaviors, which can be difficult in terms of understanding what type of military sexual trauma any one individual has experienced, but also highlights the importance of understanding that sexual harassment and sexual assault are related in important ways. This is a slide that comes from the US's Department of Defense SAPRO, Sexual Assault Prevention and Response Office, that highlights on one end of the continuum a healthy environment where there's a military climate of dignity and respect, which I think we can all agree is an ideal condition for our militaries to operate at their most effective. And then there is a continuum of sexual harassment in terms of severity, which is also related to experiences of sexual assault, all the way to the most severe forms of this experience, rape. So I think understanding the ways in which harassment and assault are related, the ways in which experiences of harassment can set the stage that allow for experiences of sexual assault to occur, is incredibly important. And I think our term military sexual trauma, in which we understand the relationship between these somewhat different types of experiences, is important for us, both in terms of preventing these experiences, but also responding to meet the needs of the victims who have experienced them themselves. I'm not going to spend a ton of time talking about prevalence statistics because their numbers around prevalence can differ for so many different reasons. Who's doing the study, how these questions are asked, whether the participants believe that their responses are anonymous or whether their confidentiality will be protected. But they are important in terms of giving a scope of the problem. Here's some recent strong epidemiological data among Canadian military personnel conducted by Statistics Canada, which demonstrates that among service members in the Canadian regular forces, about 4.5% of women and just over 1% of men reported that they experienced sexual assault in the past year. And if you look at sexualized or discriminatory behaviors, which are the kinds of behaviors that would be more consistent with the idea of sexual assault, you can see that over a quarter of women and about 13% of men report having had these experiences in the past year. I think while individual numbers can differ based on the methodology of a different study, I think we can all agree that these numbers are way too high. Even though these numbers they're important to track so that we can track the effectiveness of prevention efforts in terms of reducing these numbers. Even one experience of military sexual trauma is too many, but certainly the kinds of numbers that we're seeing in Canada, very similar numbers in US, are much higher than are acceptable for any of us. I want to talk a little bit about military sexual trauma and mental health. And I want to start by saying that there is no one mental health reaction that characterizes all survivors of MST. So for the rest of the time today, I'm going to be talking a lot about mental health. I'm going to be talking a lot about how to treat survivors of military sexual trauma. But I want to start by saying that not all military sexual trauma survivors react in the same way. For one thing, as we just discussed, MST experiences can really range in severity, with some experiences of sexual harassment being relatively low level, unacceptable, but still relatively less severe than other experiences, while other experiences of MST can be obviously quite severe. And so depending on the type of MST that any given survivor has experienced, his or her reaction may be different from what one would expect from others. I will acknowledge that most military sexual trauma survivors will experience psychological reactions, especially in the acute aftermath of the experiences, and we'll talk a little bit about why that is. But by the same token, some MST survivors will recover completely from the experience based on factors including the severity of that experience, but also the response from others after that experience, general resources like social support, availability of treatment and care, positive interpersonal reactions. All of those things are very helpful in helping MST survivors recover, many of which will recover from those experiences on their own. But there is a large group of survivors who will continue to struggle over longer periods of time. I could show you many, many slides and many, many studies that demonstrate this point. But here is data from one study we conducted within the United States Department of Veterans Affairs, which essentially compared among veterans using VA healthcare, those who had experienced sexual trauma as compared to those who had not. And we showed that those who had experienced military sexual trauma had a 3 times increased risk, even relative to the rest of the veteran population, many of whom had also experienced other types of traumatic events. And the types of mental health diagnoses that were endorsed were quite broad. Certainly PTSD, which is the disorder we most closely associate with experiences of MST, but also anxiety disorders, depression, dissociative disorders, eating disorders, substance use disorders, bipolar disorders, and personality disorders. Just makes that point that there is a broad spectrum of mental health disorders and that these experiences do strongly increase risk for diagnosis of these mental health disorders. A slide I like to show because I think it highlights, especially for those of us who are more used to working with veterans who've been exposed to combat trauma and so are familiar with the kinds of reactions there. This was a study done with US veterans after the first Gulf War and compared risks of developing PTSD among those who experienced sexual assault during their deployment as compared to those who experienced heavy combat. So among women and men who experienced heavy combat, both women and men had an increased risk by a factor of 4 for a diagnosis of PTSD. Whereas among women and men who experienced sexual assault during their deployment, those individuals were 5 to 6 times more likely to develop a diagnosis of PTSD. So much like we see in the civilian world, sexual assault is a very high risk event in terms of developing PTSD, even relative to experiences like very heavy combat exposure. I'll take a moment here. I don't really think we can interpret this difference too strongly in terms of women's 5 times more likely, men's risk 6 times more likely. Those are relatively close numbers, but I will just acknowledge many of us think of military sexual trauma as a women's issue, but in fact, a large number of men experience this as well. And men's recovery from military sexual trauma and other forms of sexual trauma can be even more complicated than their female counterparts in some ways, because men really haven't been prepared to cope with this experience in the way that unfortunately women have in our society. So I think it's important for us to remember both that men experience victimization of sexual trauma, as do women, and that men struggle with that experience like women, but also perhaps in some unique ways. So as I just mentioned, sexual assault, we know from a lot of epidemiological data, is one of the highest risk events for the development of PTSD. So compared to things like natural disasters, combat, as we just saw, motor vehicle accidents, sexual assault is a particularly high risk event. And stepping back from the military context for just a little bit, I want to just talk more broadly about sexual assault and what it is about it that leads to such an increased risk of PTSD. First, let's just start by talking about how it involves an intentional interpersonal victimization. That is, unlike natural disasters or motor vehicle accidents, and even somewhat unlike the ways in which this often plays out among veterans who've been exposed to significant combat, there is this idea that someone has done something intentionally to you to harm you. And that is a factor that we know is associated with increased risk of PTSD. Often with sexual assault, and this is true both outside and inside the military, that's a known perpetrator. So it's not just some random person doing something to you to hurt you, but someone who you know and perhaps trusted who's doing something to you. Sexual assault often occurs relatively early in development. We know that women and men who are younger in life are at increased risk, and we know having traumatic experiences early in life increases risk for PTSD. And similarly, it may be that sexual assault is one of multiple traumatic events across the lifespan, perhaps starting with experiences of child abuse, perhaps multiple experiences of interpersonal violence across adulthood, and having those multiple types of traumatic events across the lifespan is also very strongly predictive of increased risk of PTSD and more severe PTSD presentations. Another set of factors that I think we can't underestimate in terms of contributing to the impact of sexual assault is that victims of sexual trauma in our societies often encounter negative social reactions or rape myths that blame the victims or rationalize the perpetrator's actions. Essentially, incredibly invalidating responses. You can see some examples here that are associated with greater risk of PTSD. And in fact, there's a wealth of data that suggests while the sexual trauma experience in and of itself is highly predictive of things like PTSD, it is these types of reactions in the aftermath of the event that contribute very substantially to how people are coping and how they're functioning after the assault, with negative reactions being very strongly predictive of worse mental health outcomes. So take all of these factors that are true for sexual assault more broadly, and then add on the military context to begin to really appreciate why these kinds of experiences are so severe. We talked about how difficult it can be when another person, perhaps someone that you know, perpetrates a negative act against you, and how world-shattering that can be. I think within the military context, that is even emphasized because this type of behavior really violates expected trust of fellow service members, this idea of brothers and sisters in arms, and we're working together, and I'm depending on you to protect me in all kinds of incredibly difficult situations, and you violated my trust. Add to that within the military, the risk is often ongoing. There's often repeated and continuing exposure to the perpetrator, often because that involves having to continue to work and live side by side with the perpetrator, even perhaps being dependent on them for things related to health and well-being. And escape may not be possible. You can't just quit your job and walk away or decide you want to move someplace else. In the military, many people don't have that kind of freedom. So there's an increased sense of both personal betrayal, but also institutional betrayal from the organization for not having protected you. There's a greater sense of helplessness and a greater sense of entrapment, I think, compared to many civilian survivors of sexual trauma. In some ways, military sexual trauma really looks and feels thematically more similar to child sexual abuse or intimate partner violence, when a very trusted other betrayed you in a way that you cannot easily escape from. I think further, it's important to remember that military sexual trauma may occur in the broader context of chronic environmental strain. So certainly within the US military and elsewhere as well, military forces are frequently characterized by higher levels of gender-based and other forms of harassment than you see in other settings. Certainly ongoing sexual harassment, which we know even separate from a single kind of high intensity index events of sexual trauma can add to more negative outcomes. And certainly hazing related to performance. In fact, among male survivors of military sexual trauma, very high proportion of those survivors don't necessarily refer to their experiences as sexual trauma or sexual assault, although those experiences would meet the criminal definitions of those behaviors, but they just refer to them as hazing experiences. So that's another, I think, component of this whole picture. And then there are very real career consequences associated with these experiences, either because the survivor themselves says, I thought I wanted to make this my career for life, but I can't deal with this kind of behavior. It's just not okay. I have to leave. Because of military initiated career changes, either in retaliation for experiences of reporting sexual trauma, or because relationships with peers just become untenable after reporting these kinds of experiences. Or it may just be that mental health symptoms related to the MST have just interfered with career performance, leading to a career change. But for so many survivors, giving up a career in the military is incredibly difficult and leads to a strong grief reaction that is different than you see in other settings. Emphasizing this, the importance that the impact of disclosure can have in predicting how military sexual traumas recover or don't recover from these experiences. Here are a few examples from a qualitative study I've conducted among women who experienced sexual trauma in the military and what their experiences were like disclosing those experiences. I'll just read the top one here. It changed me and it made me feel powerless against everyone. I felt when someone said something, I had to abide by it because there was no one that I could talk to that was on my side. And I just had to suck it up. Again and again, among these interviews, we saw people talking about that the experience of sexual trauma was incredibly difficult, but it was negative disclosures negative reactions to their disclosures that they experienced that made them really feel these experiences of powerlessness and of betrayal. We also, though, heard some very positive stories during those interviews, and I want to include these as well as sort of an indicator of the way in which all of us can improve outcomes for sexual trauma survivors, even after they've gone through something terrible, by supporting and validating them when they disclose these experiences. So these are women who talked about disclosing these experiences to others, usually in positions of power in the military, and saying, he didn't doubt me for a second. He took immediate definitive action. When I sat there with the colonel, it's like, I knew I had somebody on my side. I really did. I'm glad that he, referring here to the perpetrator, was transferred because I didn't want to see him again. And I never saw him again. So even though I think we hear so many stories, negative stories by survivors, both inside and outside of the military, about reactions they received to these experiences, for me, it's helpful to know that there are also people having positive experiences in the aftermath of these awful experiences, and that those are so helpful in terms of recovery. Talking a bit about, more specifically, about care for survivors, and my work with the Department of Veterans Affairs in the US is really about care for survivors, sometimes many, many years after their sexual trauma experiences, as I'm seeing them as part of our healthcare system within the VA. First off, I'll just say that it is important to ask about sexual assault and related experiences. We know that many survivors don't disclose trauma history unless they're asked directly, but there have been many studies that show that sexual trauma survivors are okay and even in favor of routine screening for sexual trauma and other forms of interpersonal violence. So to the extent that we as providers are feeling reluctant to raise these experiences with survivors, I think we can feel okay, that that's an okay thing to do, and in fact is viewed positively. Certainly, knowing about a sexual trauma history can provide context for presenting problems as mental health or physical health providers. Asking about this, even for those who haven't experienced sexual trauma, can convey that as a provider, I'm okay talking about difficult topics, and can also communicate essentially that me as a provider and also the healthcare system that I'm representing really care about this issue. In support of this idea that it is important to ask survivors, within the Veterans Health Administration in the US, we have universal screening for military sexual trauma, meaning every veteran, male and female, is asked by a medical provider if they experienced sexual harassment or sexual assault during their service. It happens as part of our integrated electronic medical health record, and it's important both for the reasons we just talked about, but also because this is an indicator within the medical record that this veteran should receive care, free care, for any experiences, any diagnostic conditions that within the opinion of the treating provider are related to this experience of military sexual trauma. It's a very broad healthcare eligibility program that I'm very proud of related to military sexual trauma exposure. Just to give you a sense of what the data looks like when we pull the data up for the about 5 million veterans who we see 30% of women and close to 2% of men endorsing these experiences. And you can see this relates to a large number of women and a very substantial number of men as well. These numbers are lower than you see in sort of well-designed prevalence studies, and in fact have been growing over time, which I think reflects not an increase in the proportion of our veterans who have experienced these events necessarily, as much as it reflects the fact that we as a healthcare system, I think, are doing a better job in asking these questions in a way that allows veterans to feel like they can disclose these experiences to their providers, even if they've had negative disclosure experiences in the past. And to that point, we've done a lot of work within VA, understanding what patient preferences are for sexual trauma-related communication with their providers, because a trauma-informed approach really suggests we should be following patient preferences and letting that information guide us. So having these instructions be brief, clear questions, certainly offering referrals and resources, doing this with a compassionate and non-judgmental stance where you're allowing patients some control over when they disclose this information and how they disclose this information and how much. Many sexual trauma survivors have a preference about the gender of their provider, and this was something that they pointed to as important in terms of their feeling able to disclose, and often that these disclosures happen in an ongoing trusting relationship with a provider. In terms of the issue of being able to offer resources, I wanted to just talk very briefly about a mobile app my team has created and released. We are close to 6,000 downloads now since it was released earlier this year, and can be a really nice self-help product to offer someone after they've disclosed experiences of MST, even if they're not sure if they're ready to seek further care. I'd encourage you to check it out. We're extremely proud of it, and I think it can be a very validating experience for survivors. Beyond these kinds of self-help resources and thinking about mental health care for MST-related PTSD, I really think of best practices as including first taking what we know about evidence-based treatment strategies that are broadly relevant to the treatment of PTSD, but applying those while attending to complex presentations or common treatment themes that currently arise when one is working with MST survivors. So I'll talk a bit more about both of those. These are the types of evidence-based psychotherapies for PTSD that are strongly recommended for adults. This particular information comes from the International Society of Traumatic Stress Studies, recently released guidelines for the prevention or treatment of post-traumatic stress disorder. I think many of you are likely familiar with these therapies. But in terms of thinking about the types of additional issues to be attuned to among military sexual trauma providers, complex traumas of the type we've been discussing lead to complex presentations, including psychiatric comorbidities, self-injurious behaviors, and I'm thinking of that in a way that's very broadly defined here. Certainly struggles with emotion regulation or distress tolerance, negative views of self, including self-blame, challenges in interpersonal relationships, including trust, very understandable given the nature of this trauma, and also given the nature of the trauma, perhaps difficulties with sexual functioning or sexuality. So one question I frequently get is it okay to use these evidence-based therapies for PTSD with these kinds of more complex PTSD populations? And the answer is yes. Things like prolonged exposure and cognitive processing therapy and EMDR have been tested among populations with these kind of more complex presentations. And there is some evidence that they don't work quite as effectively among these complex presentations as opposed to more straightforward presentations, but they are safe and they are effective. And so given the strong support for their effectiveness as treatments, they should always be considered as first-line treatments. We deserve to be giving these survivors the best possible care that we can. And I think these evidence-based treatments are the way to do that in the context of understanding the complexities that go along with these trauma presentations. I want to just end by sharing a few words of resilience for an MST survivor who was involved in one of my qualitative studies. She said, I wouldn't take away chapter 1. It all flows from the first chapter. It all flows and it's all part of the end of the book that I haven't come to yet. I'm more peaceful now because of the chapters in the book and the way they flow together that have made sense of a chapter 1 that was pretty drastic and dramatic. I feel more at peace now and it's good. I'm constantly amazed by the resiliency of the women and men who I work with in overcoming these experiences. And I thank you all for the opportunity to speak today and also for your support of all survivors of sexual violence. Thank you.
Thank you, Dr. Street, for an insightful presentation on an incredibly important topic. Let's all commit to continuing the conversation on military sexual trauma. This brings the main plenary for the veteran session to a close. I would invite all of you to join session A or B, or switch between the two for the rest of today's oral presentations. We have added a 5-minute buffer between this main plenary and the start of the next sessions. If you run into any technical difficulties, please don't refresh. You will enter the session shortly. We have over 1,000 registrants for CIMVHR Virtual Forum, and it takes a few minutes to get everyone into the sessions. Thank you all for participating, and I appreciate your patience.